it looks like we've got a great group. We are going to be hosting our Chief COVID Officer, Dr. Dale Bratzler. Dr. Bratzler is a professor and chair of the Department of Health Administration and Policy at the Hudson College of Public Health and professor in the College of Medicine at the University of Oklahoma Health Sciences Center. He also serves as the Enterprise Chief Quality Officer for the 3-hospital health system and faculty practice at OU Medicine. Dr. Bratzler has served 2 terms as president of the American Health Quality Association and is a past member of the Agency for Healthcare Research and Quality National Advisory Council and the CDC Healthcare Infection Control Practices Advisory Committee. He has given more than 600 lectures nationally on healthcare quality topics. Board certified in internal medicine, he is a Master Fellow of the American College of Osteopathic Internists and a Fellow of Infectious Diseases Society of America. Please join me in welcoming our very own Dr. Dale Bratzler.
Good morning, everybody, and thank you, Nancy. It's really a pleasure to be here. Seeing this many people on a Zoom call reminds me of my favorite Saturday Night Live skit that was actually funny recently. If you haven't seen it, just Google after this call, Saturday Night Live church service via Zoom, and it's actually pretty hilarious and reminds me so much of all the things that we've been doing with respect to our changed world now for having meetings. So I'm going to give you a brief overview of COVID-19, and here's what I thought I would do. I'm going to just give you a brief overview of kind of where we're at right now with the pandemic in the United States, and spend a little bit of time talking about where we're at with the pandemic in Oklahoma, some of the policies. I'll spend just a couple of minutes referring to the return plan for the Health Sciences Center, though I'm not planning to go through that in detail. And then what I really want to do is leave plenty of time for questions for people who have issues that they want to talk about as we continue to navigate this pandemic. As I've told many people, there is no playbook here. When President Harris asked me to take the role of Chief COVID Officer, it became quickly a daunting task thinking about how we keep, everybody on 3 campuses safe. Particularly, we've got 25,000 Norman students, undergraduates coming in within about a week or so. So there is no playbook for this on how you reopen. I have so many primary and secondary school administrators contacting me now because they're all struggling with, how am I going to know when it's time to pull back or go online, things like that. So let me just give you kind of a brief overview of where we're at. And then we'll have plenty of time for questions. I always learn a lot from participating in these events with you. So just remember when. It seems like eons ago, but it was only December 31st that we first learned about this new viral illness that was spreading through China, causing pneumonia of unknown etiology at the time. There's now good evidence that the pandemic was spreading through provinces in China probably well before December, and there had been unrestricted air travel throughout the world to China at that time. So clearly the pandemic was already spreading before we even knew about it. The virus eventually was identified. It's SARS-CoV-2. It is a novel virus, and the reason I highlight that is because it's very contagious, and because humans had never seen this virus before, it spreads easily in our population. You don't have immunity to it. Most of you, probably at some point in your life, in fact, perhaps all of you, have been infected with a coronavirus in the past. Coronaviruses are common, cause things like the common cold, upper respiratory infections, but this particular virus seems to be much worse, causing many symptoms. And again, there's no immunity to this particular virus. Let's just highlight a couple of things that we've learned. I think we know pretty well now. First, I'm sorry, some reason jumps on me. The virus is primarily transmitted person to person when you breathe droplets into your, into your mouth or lungs, into your nose from people around you. It's usually close contact, and it's droplet spread. Now, we could argue all day about whether it's aerosols or droplets, but it's moist droplets that are coming out of your mouth. And I'll show you in just a moment, even when you breathe, but when you breathe, when you speak, if you're singing, if you're coughing, sneezing, droplets come out of your mouth. They get into the air around you. There's a plume of them. And if other people breathe those, and those droplets have to be contaminated or infected with the virus, then you could get infected with the virus. That by far is the primary mode of transmission of this disease. There's has been some discussion about, do you get it by touching a surface or an object that's contaminated with the virus? And theoretically, it's possible, though the CDC strongly feels now that that's not the main way the virus spreads. I highlight that in particular because particularly out in the community, there are so many people that have been talking about, are you getting contaminated? You're not wearing your mask right. So you're touching your mask and then you're contaminating yourself. And so masks obviously just don't work because they're contaminated. In reality, in the community, that's probably not a common mode of transmission. Most of it's from breathing droplets that come out of somebody else's mouth. Now, I'm not going to play it today. I've tried it before, but I will send out this slide deck. There's a YouTube video. It's 2 minutes long. That is a great teaching tool that shows what happens when they use laser light to do photography of somebody who's talking. And they show all the droplets that come out of your mouth when you talk. In that same video, they put a simple cloth mask over the research participant and showed that the cloth mask dramatically reduces those droplets that come out of your mouth. There are numerous studies that have demonstrated that now, that when we wear a mask principally for source control, in other words, to prevent the droplets from coming out of our mouth and getting out into the air around us, that plume that I talked about. So we'll send that out, but I encourage you to watch it. Use it with your coworkers and others, because I think once they watch it, they'll get it about why we're so highly encouraging masks to prevent transmission of the disease. These are the symptoms. This is certainly something that's evolved with our learning about COVID-19. The common ones that we used to talk about all the time were fever, cough, shortness of breath. Frankly, most of us in the healthcare setting don't even recommend temperature taking as a screening tool very often anymore. And there's nothing wrong with doing it, but just remember the majority of people won't have a fever, particularly when they first present with the disease. But there are many, many other symptoms: fatigue, muscle aches, headache, loss of taste or smell seems to be particularly common in younger people, sore throat, congestion, runny nose, nausea, vomiting, diarrhea. There's a host of symptoms that occur. This is a poster from the Centers for Disease Control that you can freely download if you'd like to have the poster. But just remember, there's a host of symptoms that could predict somebody might have COVID-19. The other thing I think is really important to understand is that you live in a state where there are a whole bunch of people who are susceptible to this infection. So in this particular study, which was published by the CDC on July 24th, they looked at the prevalence of lung disease, heart disease, diabetes, chronic kidney disease, and obesity, all known risk factors for both getting this infection, but also having more severe outcomes if you get the infection. So the darker the color, the more people with that one of those particular conditions. And as you can see, Oklahoma's pretty dark, perhaps not quite as bad as Louisiana or Alabama, but West Virginia obviously has a huge proportion of their population that are susceptible. But there are other diseases, though, that we know do make you susceptible to this disease. And this is data that comes from the Oklahoma State Health Department. Clearly, we know that patients with cancer, or even who have recovered from cancer, immunosuppressed patients, chronic liver disease patients and patients who have sickle cell disease are also at risk of the disease. So just recognize we live in a state with a bunch of people who are at risk of this infection. I think it's part of the reason we're seeing quite a few deaths right now in Oklahoma. Oklahoma was ranked 13th in the nation of having the most people who were the highest proportion of the population susceptible to this particular infection. This data is a little bit old. I updated the slide on July 30th, so it's 4 or 5 days old, but at that time we were at 17 million cases of COVID-19 globally since we first learned about it in December. I know we've eclipsed 700,000 deaths now globally, and in the United States we're over 4.5 million cases in the United States, and I think we're right at about 160,000 deaths in the United States. So I do tire a bit of all the people telling me that this is just like another flu and stuff. We don't see this number of people die from the flu. We don't see hospitals in Houston, New York, and other places renting refrigerated trucks for the bodies in flu, the annual flu infections that we see. And I think the United States right now, we're hovering somewhere around 1,000 deaths a day in the United States from COVID-19. So this is truly a pandemic to be concerned about. So here's Oklahoma data. This is updated as of yesterday. There are 40,564 confirmed cases in Oklahoma. Now, remember that once you get out about 2 weeks from your diagnosis, you're considered recovered from the disease. There have been 583 deaths, but this number has been going up pretty rapidly recently. And so what I highlight is you see all of these new cases. I'll show you in just a moment, but in Oklahoma, 10 to 12% of the people who get the infection, who go out and get a test and have a positive test, of those people, 10 to 12% will end up in a hospital. Now, recognize there are a lot of people, 40% of the people who get the infection are asymptomatic, never have a symptom, they look perfectly fine. The other thing to remember is, or they may be minimally symptomatic and never seek a test. They never get a test done. And so those people have a much, much lower hospitalization rate. But if people go to get a test done, which tends to be more commonly people who are having some symptoms or something, 10 to 12% of those people end up in the hospital. And that's why I think because we have so many new cases now, I'll show you in a moment, we have a lot of hospitalizations now. We're going to see people dying in our state from this disease. The number I look at every day is the 7-day rolling average, which tells me the average number of new cases per day in Oklahoma. And right now we're at about 850 new cases on a daily basis in Oklahoma. We have gotten up as high as 1,100. And in fact, I got a concern last week when we hit 1,100. And I sent a note to President Harris and said, I think we need to revisit everything we're doing if we continue to see this rate of growth in new cases in Oklahoma. So as of yesterday, 850 new cases on average daily. Oklahoma County and Tulsa County have been hit the hardest with the number of cases. Oklahoma County has the most. Tulsa County actually was ahead for quite a while, but Tulsa County now has dropped back. Tulsa County had a number of outbreaks that happened. Some of them before the big rally. There may have been a rally impact of the disease. But just look yesterday alone, the Oklahoma State Health Department reported 357 new cases in Oklahoma County alone. We've had a fairly substantial outbreak in the Hispanic Latino community in Oklahoma County, which has accounted for a lot of cases. Some of my friends in clinics in Southwest Oklahoma City have seen rates of positive tests of up to 30%. In other words, for every test they do, 30% have come back positive. And that's one of the numbers that we watch carefully. In fact, here is that number. This is statewide data. So this isn't Oklahoma County, this is statewide data. The lowest this number ever was the week of May 25th. The week of May 25th, the state ran 33,593 COVID tests. Only 1.8% of those tests were positive. Last week, we ran 70,857 tests, so no doubt about it, we're doing more testing now than we did early in the pandemic. But 10.7% of the tests that were run were positive. So that tells me more people are infected. It's not because we're doing more tests. More people are infected. So we've been hovering right around 10. This week it's been hovering right around 10.5%. It hasn't changed much. By the way, this is one of the numbers that I track very carefully. I actually track it every single day because I would expect that if we see impact with face mask mandates in areas of the state, we would see this number start to trail off first. And I just saw data literally in the hour before this call from our Norman campus, and I was very, very happy to see it because Dr. Rice, the medical director for the Goddard Health Center, has been tracking all the tests that they do at the Goddard Health Center and looking at the percent of those tests that were positive. At one point, we hit 12% of the tests that we were doing at Goddard were positive. I think he told me this past week it got down below 3% of the test run at Goddard were positive. Remember, we have a mandatory mask policy at the university, but Norman also has a mandatory mask policy. So very, very happy. It's exactly what I would expect to see if mask mandates work. And it's why I've been such a vocal proponent, even though the governor may not like what I'm saying, that we should have a statewide mask mandate. Because I think it's one of the ways we get back to some rational sense of normal is if we stop the spread of this disease. Here's hospitalization. These are total hospitalizations. Highlight a couple of things. Number one, we have more hospitalizations now than we had back at the start of the pandemic. Remember, the governor and everybody else kept talking about, well, you know, our big peak was in March, April. And we did have a big peak. But there was a very different character of the patients that were in the hospital then versus now. A lot more of the patients who died early in the pandemic were from nursing homes. This was before we knew how to keep it out of nursing homes. And we, as you all know, we saw outbreaks in nursing homes. We had a lot of deaths in nursing homes. We actually had quite a few healthcare workers in nursing homes who got quite ill with the disease also. But I don't know if you can see the difference in the colors between the blue and the crimson, but you can see that in the early part of the pandemic, most of the people in the hospital were people who were under investigation. We were waiting on a test that wasn't back yet. The blue color was those who had a positive test. They were in the hospital. And some proportion of those persons under investigation do end up being confirmed cases. But I will tell you right now, when you look at the proportion of people who are in the intensive care unit, really sick with this disease, the ones who are sickest are the ones who have the positive test. So as of yesterday, we had 643 patients in the hospital in Oklahoma with COVID-19. And here I would argue that here I agree with one of the things that the governor's been saying is that it seems that at least our hospitalizations have seemed to plateau now for the past 3.5 weeks, that we've kind of hit this 600 to 650 range and we've kind of stayed there for the past 3 weeks. So maybe we're starting to see some plateau of the disease. But here's confirmed cases. I don't know what happened to all of the details of the axes, but as of yesterday, we had quite a few people in the hospital with confirmed cases. But you see now, today we have a lot more people in the hospital who have a confirmed case than we did way back in March and April. So that's one different characteristic of the disease. The other thing that doesn't show up here, it was on the slide, I don't know where it went, but for the past several weeks now, 40 to 50% of the confirmed cases who are in the hospital are in an intensive care unit bed. So we've had fairly consistently more than 200 people a day in Oklahoma in an ICU bed because of COVID-19. And that's why in the press, I've been very vocal that we're going to continue to see deaths because you don't have 200 people in an ICU and don't expect some people to die from the disease. So that's just the reality. And that's why I think, you know, just in 2 days this week, we saw more than 30 deaths from the disease. Okay, so that's where we're at. So what can we do about it? Well, you've probably all heard about the vaccines that are out there. There are at least two in clinical trials now, what are called phase 3 clinical trials, where they plan to test them with 20 to 30,000 patients. In fact, I know two of my staff on campus this week actually enrolled and participated in the trial of one of these vaccines. So they are available in Oklahoma in some research settings. You don't know whether you're going to get a placebo or you're going to get the actual vaccine if you participate. But nobody anticipates we're going to have a vaccine before the end of the year. And just think about it. In Oklahoma alone, if we had to have 70% of Oklahomans immune to this disease to finally reach what we call herd immunity, where people don't spread the virus very easily anymore, we'd have to vaccinate 2.8 million people minus whatever percentage have already had the disease. So it's going to take a while for any company to produce just the sheer volume of doses that we will need to vaccinate a big proportion of the population. You probably, if you've been on the internet at all, know that there are lots of people, including doctors, selling tons of things that they say will cure the disease: medications, vitamins, supplements, or they'll either prevent or cure the disease. None of them are proven. There have been no good trials for any of them. There's a physician in Texas that's promoted one of the asthma inhalers. I get questions about it all the time. I've done multiple literature searches. There are no randomized trials that show that it helps. There may be a theoretic reason it might help, but it needs to be subjected to a study. So in the absence of any way to prevent it, no vaccine, no medicines, vitamins, supplements, or anything else that have been shown to prevent the disease, the best way to prevent the disease is through public health interventions to avoid being exposed to this particular virus. So being in crowds, not wearing a mask, not doing good hand hygiene, not physically distancing yourself are all risk factors to get the virus. Because remember, you primarily get this virus by breathing in droplets that have come out of somebody else's mouth. And typically, most commonly, most of the studies still show that the vast majority of those occur where you're in a place with close quarters. Treatment's gotten better. I'll just say that more of the patients in ICU do survive now because we're better at supportive care. We have plenty of personal protective equipment. Nursing homes have actually become pretty safe. Remember, most of the infections were brought in either by visitors or by staff who were infected. But you can't get into a nursing home as a visitor now. And if you work there, you have to be in personal protective equipment. So they've gotten much, much safer. I feel very, very safe on the HSC campus because we have policies of absolute wearing masks and other things. So I feel safe and we should reduce risk. A number of drugs have been shown to either reduce mortality or shorten hospital stay. The two in randomized clinical trials, dexamethasone, which is a steroid we've had forever, reduces mortality, particularly in those people that are really sick that need to go onto a breathing machine. And then remdesivir, you may have heard about. We are using adhered OU medicine. It reduces death rates and primarily also reduces length of hospitalization. And then the one I didn't put on here is convalescent plasma. Most of the clinical trials are still ongoing, but that's taking the plasma from somebody who has had a confirmed case, recovers, taking their blood, giving them their red blood cells back, but transfusing their plasma into somebody with the infection, hoping that their antibodies will help fight the disease. I've seen some studies suggesting that it's working, but most of the studies are still ongoing. The other thing that I learned a couple of weeks ago in a continuing education course is that there's some evidence that if you can reduce the amount of virus you inhale, so even if you get infected, if you inhale less virus, you will likely have less severe disease or maybe even asymptomatic disease. That's been shown in influenza in the past, and there are a number of studies now that have shown that even in communities that have community-wide masking policies, they're seeing more asymptomatic cases of the disease than symptomatic cases. So masks aren't perfect, but if you can reduce the amount of virus that you actually inhale, that may be useful to you and protect you. Well, let me just touch on a couple of things about campus reopening. Those policies are out now. I know there's going to be some very slight revisions that'll be coming out soon. But a couple of points I wanted to make, and there are a group of dedicated leaders from across this campus who are working tirelessly on COVID-19, who have nonstop meetings about things we need to do to keep the campus safe, keep our patients safe, keep our staff, faculty, and our students all safe. And one of the decisions that we made, and you've seen it in the reopening plan, is that if there are employees who can do their job effectively remotely via telecommuting, then we're still encouraging you to do that rather than bringing them on campus. Although I have some people say it's safer at work than it is to stay at the house with the kids at home. But again, it's up to each college dean and area vice president or their designees to make those determinations. So look at the policies, they're out there. But I anticipate, and frankly, if you look at healthcare nationwide, it's changing. People are questioning, do we need all the buildings anymore? Because, you know, when you think about finance and billing and grant support and things like that, you can do that work from a computer anywhere. Don't necessarily have to be aggregated on campus. So there's some areas of work that can be done. And again, there is a telecommuting policy that you can link on the OU website. Mask, one of the very first things, we'd already done it on the HSC campus, but one of the very first things that I did when President Harris asked me to be the chief COVID officer was insisted that in all university facilities, cars, shuttles, buses, buildings, that you have to wear a mask. I'm not wearing a mask at this moment only because I'm in my private office and there's nobody else here. And that's one of the few exceptions for wearing a mask. But otherwise, you have to wear a mask. As you know, on our buses, our transport on campus, on all the campuses, we reduced the number of seats. And again, we require masks to be on those. The only ones that we don't allow are scarves or bandanas, which actually I can show you studies that have shown that they're not very good at source control. Things leak out around them, and they're not very good for that. Mask must cover both the nose and the mouth. I will tell you that we do have, we don't like to call them mask police, but we do have people that are auditing around campus looking for people wearing their mask. Which includes visitors, employees, staff, vendors, anybody who's in our facilities. We want them in a mask to make it a safe environment. Now, here's the latest of the big controversies. You can buy these masks anywhere, but there's growing concern about all of these masks that have valves. This is a picture from Amazon.com of some of these masks that are sold. They look really cool, and they have this disc. It's a one-way airflow valve that only lets air out. So a lot of them have changeable filters that you can put in, but the air that's coming out typically is not filtered. It's only the air coming in. They release, as you can see, stuff comes out. That's what their purpose is to make it easier to exhale. But that also means you're potentially defeating the purpose of source control by wearing masks that have a valve. So CDC actually recommends against their use. The plain cloth mask that many of you have seen, the ones that have been made at the churches and other places actually are quite effective. You'll see that when you watch that short video. A simple cloth mask very effectively stops droplets from coming out of your mouth and may give you a little bit of protection by preventing you from breathing in as much virus or droplets. So that's what we want, is we want people universally in mask. We're trying to decide on the HSC campus because we know people have purchased these, about whether we look to whether we allow people to wear those that have the exhalation filters or valves, because CDC recommends against their use. couple of other things I just want to highlight. If you go to the OUHSC website now, there's a button down here that you can click on Learn More about COVID-19. I just wanted to highlight this again. Many people have worked on improving this, but it takes you to the mandatory COVID-19 screening reporting tools. So if you've been off campus for 7 or more days, you're required to complete the COVID-19 screening and reporting tool. But I also want to highlight the second link. If you're in an office that's bringing a vendor or a visitor, they have to complete the screening tool also. They are also subject to the masking requirements when they come on campus. So I just wanted to highlight that we're trying to very much control who comes on campus and how they do it, so we keep our campus as safe as possible. So in summary, we have a virus that's very, very contagious, and most Oklahomans are not immune to it, are still susceptible. In the absence of a vaccine or any known treatments to prevent the disease, the public health interventions that you've heard ad nauseum are the only ones that have been proven to reduce the spread of the virus. Avoiding big crowds, physical distancing, wearing a mask, doing hand hygiene. The other thing I highlight is personal responsibility both on and off campus. I actually feel very, very safe on campus. I probably feel less safe if I go out into public outside of campus. You know, the Oklahoma City County Health Department has identified places where your risk of infection is just higher. How did they come up with this list? They came up with it by talking to people who got the virus. So restaurants, daycares, office settings where people aren't wearing masks, faith-based venues, like it or not. Churches aren't immune from the spread of this virus, and very, very sadly, many have not mandated masks, which is, in my opinion, inappropriate. Manufacturing warehouses, you're all assembly lines, meat packing plants, chicken plants, and others. But the others that they've highlighted in the past, they didn't put on this most recent 5 list, are bars. Bars are particularly high risk. Think about it. Nobody's wearing a mask when you're drinking. You're in close quarters talking. People are loud. I heard a bar this week that banned the singing of the song Sweet Caroline, you know, Neil Diamond song, because everybody really gets into it, starts singing it really loud, and they're afraid that it's spreading COVID-19. Family gatherings where you have large groups of people, particularly people who don't live together routinely, that's partly a risk. And then just parties in general. For those of us that are dealing with opening of the Norman campus, obviously we have enormous concern here and are working very carefully with the city of Norman about how we limit some of these activities from happening for spread of the virus. So Nancy, I'm going to stop there and happy to answer any questions.
Wonderful. Thank you so much, Dr. Bratzler. That was great information. I'm going to go through the list here of the questions that we have. Some of them he's already answered, so I'm not going to address every single question. If you feel like your question's not answered through this session, please send me an email and we'll compile those questions to be answered at a later time. So a couple quick things. I'm going to go over some mask questions first because there seems to be a lot more of the mask questions. First, the very first question actually, Dr. Bratzler, was, can you show us the proper way to actually be wearing a mask? We see lots of people with their nose exposed, some with not properly placed on their chin. Could you show us that, please?
Yeah, so here's my cloth mask that I wear. It's a multi-layer with a filter in it. I typically try to hold on to the straps to pull it on and put it over my ears. It's covering my nose and it hooks under my chin. So you definitely want to make sure you cover your nose when you're wearing your mask, and then removing it's the same way. Now, I will tell you, I was with a group of experts that did a fun panel discussion of masks for the Science Museum this past week. And in healthcare, if you're staff that work in an intensive care unit, you're in a high risk area. See Dr. Comia on, where dentistry is such a high risk area. We actually worry about contamination of the outside of those masks because you could be in the face of a patient and get lots of droplets and other things that contaminate the surface of the mask. So in those circumstances, I think you need to be, when I'm in healthcare, when I'm seeing patients, I'm wearing an N95, and I'm very concerned about how I touch that mask. I don't want to touch the outside of it. If you're, a business administrator, you never see a patient, you're never in the face of a patient. I think your risk of serious contamination of the surface of the mask is much less. We don't think the virus lasts very long on any cloth surfaces. So the big questions were, I've heard legislators say they're no good because people don't know how to use them, and they're doing all sorts of inappropriate things like, pulling them out of their purses or hanging them on the rearview mirror. I actually have no problem with that. The most effective mask is one that people will wear. And whatever it takes to get people to wear masks, cover the nose and mouth, I'll support it. So again, that's why I highlighted early in my presentation, contaminated surfaces, while it's theoretically a way that this virus can be transmitted, it's probably not the common one.
Alrighty. The next question about masks is, are the Gator type masks that professional athletes use effective?
The Gator type mask? Guess I don't know a whole lot about them. Again, I'm happy if anybody wears any type of a mask. The only ones that I do think we're having a serious conversation about right now is the masks that have the valves, the exhalation valves. We don't wear them in healthcare. Our N95s on campus do not have exhalation valves. If again, it completely covers the nose and mouth, that's going to stop most of the droplets from coming out, and that's what's important. The other point I make about masks, I actually strongly support universal masking in gyms. I don't think that should be an exception. Great credit to the athletic department down at OU, because when I went down and visited the training facilities, not only have they done all of the really important work of physical distancing, limiting the number of student athletes that can be in the locker room. They don't let them shower there anymore. All their food is grab and go, no buffets, none of that type of stuff. But they make them wear a mask for everything. Weight training, aerobic training. The only time they get to take their mask off is if they are outdoors and they can physically separate. So if you look at most of the media interviews with Lincoln Riley and the football players, you'll see them. They're wearing masks. So don't tell me you can't do it. You can. I know it makes it maybe a bit harder to breathe, but it is feasible. And we made all of the student athletes, basketball, football, all of the players are wearing masks when they're working out.
All righty. Thank you. Do you think that the state is doing enough testing, and what is the average turnaround time for the COVID testing?
Yeah, it's a great question. So I would say in general, we don't do enough testing. And honestly, I don't know that we're ever going to get there with the current requirement to go and get swapped somewhere and get the testing done. There are a host of new tests that are going to come out that are cheap, that are at home, that are kind of like pregnancy tests and other things. They won't be as sensitive, but because they're so inexpensive, you can do them often. And that's what we're going to have to get to, is inexpensive tests that are easy to do and do often to really get this disease under control. So, we've ramped up at OU Medicine now. Our turnaround is never more than 24 hours. We have unused capacity at the OU Medical Center laboratory right now to do COVID testing. And we get most of the results the same day, but some by the next day. But we always get them by the next day. Now, the state health department, who we've been running them for, may not always get the results back to the individuals that quickly. But I know I see Kristen on the call, and I know her team has been calling the positives, and then you may wait 10 days or more to get a negative call from the state health department. We need to do more testing. It needs to be easier. Right now, the average cost of a test, just so you know, is in the $80 to $100 range if you were paying for them. I know that because we just tested 5,000 students in Norman. we need to get down to where we have $25 or simple tests that you can do often at home.
All righty. Until recently, repeated testing was performed to determine if a person was still infectious. Do we know that each test represents a unique person, or could earlier data include repeat?
Yeah, so the state health department, since day one, so I'm always very careful if you look at the slides where I distinguish specimens tested from individual new cases. The state health department deduplicates anyone who has multiple tests and only will report that individual once. But every day they also report all the specimens they tested in the state. And some patients, remember, a test today, a negative test today means you're negative today. It doesn't mean anything about tomorrow. So I think we're going to see a lot of people that have multiple tests, but once you're positive, you're identified as a new case once. There is no credible evidence that anybody has been reinfected with this virus. There are all sorts of anecdotes, but there is no proof that anybody has ever been reinfected with COVID-19. So in the past, the CDC recommendation was that somebody was positive, then you wait perhaps 10 days, 2 weeks, retest them. If it was negative, they could return. If it wasn't negative, you retested, wait another week. We don't do that anymore now. The CDC guidance is really clear. If you have a positive test, 10 days have elapsed. If you had symptoms, they're improving, and if you had no fever for 24 hours, you can go back to work. We assume that you're not infectious anymore, and they do not recommend repeat testing.
Excellent. The next question is, do asymptomatic persons show a reduced oxygen level when infected, or are there any other indicators one might be able to use?
Yeah, so truly asymptomatic people may not show any symptoms at all, though I have seen a few reports that if you did things like measuring pulse oximetry, even on people who are negative, you may see some changes in their pulse oximetry. But most of them, there's no way to know. And so I didn't put the slide in, but I have a slide that I use with all the students, which I highlight as universal COVID precautions. Just assume anybody you encounter could be infected. It doesn't matter if they had a negative test last week, because if they went out into public over the weekend, they could have gotten infected. You just have to assume that anybody you encounter could be infected, because they can look perfectly normal, have no symptoms, be positive, and be spreading the virus. So that's why I'm such a strong proponent of universal masking, because we're not going to control this disease until we stop the asymptomatic spread also. And the only way to do that is to say everybody's in a mask. I honestly think that Robert Redfield was correct, that we could see a dramatic reduction in the case counts and other things if we just go to universal masking.
Alrighty. If I wear a mask and eye goggles, do you think it's safe currently to fly commercially?
Yeah, that's a great question. I was asked it on the news yesterday. I heard a great presentation not long ago by a public health professor from the University of Massachusetts who studies these plumes of droplets that come out of your mouth when you're speaking and other things. And he talked about something called the heat plume. Your body's warm and air rises around you because of it. And when you're talking or breathing, droplets are coming out of your mouth and they go up. On airplanes, most of the airflow comes out of the top of the plane. You see it, that comes down either out of the vents or out of the louvers that they have at the top, flows down to the bottom, and then it does go through HEPA filters. I mean, airplanes are definitely a lot safer than they used to be. My one admonition is wear the mask. If you want to wear eye goggles also, I have no problem with that. And I think that makes it safe. Just don't take them off to, be drinking, eating your pretzels and that type of thing. Because whether you like it or not, you're in close proximity to a bunch of people on a plane.
All righty. One of the news stations have reported that faith-based groups must be under 500. What are the current recommendations of numbers for groups at this point?
Yeah, I don't know if Jill Raines is on the call, but we've had that conversation numerous times here on campus about what number should we limit, particularly outdoor activities. Indoor activities, any place you're inside, I don't care whether there are 20 people or 500 people, you're at increased risk if you're in close quarters and you're not wearing a mask. What about outdoors? Any number is arbitrary. I mean, there is no scientific basis for any particular number. So I think where we're headed, and again, I don't want to say something incorrect if Jill's on the call, but I think where we're headed with the university policy is, as long as you can physically distance yourself outdoors, it's safe to have gatherings outdoor, but you have to physically distance, and preferably if you're in a crowd, I've gotten to where I just wear my mask all the time when I'm outside of my office, even when I'm outside hiking across campus, because I don't encounter a lot of people, but it's just easier, and frankly, I'm used to it now.
Hey Dale, it's Jill, and I am on. And
all right. The
right.
police are there.
We're actually, there's a group that'll be talking about this afternoon. So before you start planning any groups, wait until any decisions made final, and we'll push that out as a change to the plan if we have a decision today. So you'll hear soon about any change to that. But that's currently been that is the thought process, just not finalized yet.
Okay, so you all heard how I always defer to Jill Raines whenever I say anything that could be controversial.
All right, thank you. On to the next question. If someone at our office or work area tests positive from an unknown source, what is our exposure risk in the office?
Well, if everybody's in a mask, your exposure risk is very low. And so typically, contact tracing is initiated if you're within 6 feet of somebody for more than 15 minutes. Particular risk is if you're unmasked. So that's the policy we set up in the classrooms in Norman. All the students have to be at least 6 feet separated from every other student, and you have to be in a mask. The professor has to be in a mask. And actually, in that circumstance, I feel quite comfortable. And I actually have no doubt, I teach on the Norman campus, that I'm going to go into the classroom, and unbeknownst to me, there'll be some student who looks perfectly normal, who's positive and has the virus. But again, I will be comfortable if we can physically distance and wear the mask. And that's why we have that universal policy inside of any university facility.
All righty. How can we distinguish between COVID symptoms and typical allergy symptoms?
Well, you can't. And so that's where we need easy, broadly available testing, so that people can get tested if they have concerns at all. I mean, if you're a person who every single year suffers with seasonal rhinitis, and those, it happens every year. I'm not saying that everybody needs to run out and get a test every time they cough or have some congestion because they're been outside working. We actually have a barn on our property with hay in it, and if I'm in the hay long enough, I start sneezing and other things too. And I know it's going to happen, but you can't, and that's the problem. And so we haven't talked about it a lot yet, but we're not far from flu season. You can't tell the difference in the symptoms of flu and COVID-19. So we're really, really, really going to be promoting and want as many people as possible to get vaccinated against influenza this year, not only to reduce the burden on our hospitals and our workforce, but also to help us distinguish, reduce perhaps some of the people who have an illness that looks like COVID that could be influenza.
All righty. Does the face shield offer as much protection as a mask?
Yeah, it's a great question. So there's pretty good research, particularly in influenza, that shows that when you wear a face shield, it protects you. They're pretty good at protecting the person wearing them. What there is no evidence is do they provide source control? Because if you cough or sneeze or talking, droplets can come out around the face shield. And so there's no good evidence for source control. So we are limiting face shields to very limited circumstances where there are people who, for some reason, can't wear a face mask that have a legitimate reason. And by the way, there aren't very many legitimate reasons that you can't wear a face mask. There just aren't. So I did have to make an exception. Dr. Linda Salinas and I working for patients who are doing pulmonary rehab walking tests. It was very difficult for them to wear masks, so we put them in an enclosed hallway where they're not exposing other people, but we allow them to wear a face shield. That's one example.
All righty. If someone has been exposed to COVID and gets tested and they test negative, should they be retested 7 to 10 days later? And are rapid tests reliable?
Yeah, so two great questions. So we know now that when you're exposed to COVID, let's say you're exposed to somebody and you get infected, if you get tested immediately, there's a very, very good chance that you will have a negative test. In other words, there's a high false negative rate early in testing. And it seems that the PCR test, the nasal pharyngeal swab test, are best when done anywhere from 5 to 7 days after the infection starts. So just realize that one negative test does not mean that you did not get the infection. Now, do you need to be retested? And this question comes up to me all the time. So the typical scenario is I was exposed to somebody 9 days ago, and, should I get tested now? Or I had a test, the day after that, it was negative. Should I get tested now? Well, remember the CDC guidance is if you're 10 days out from exposure and you're asymptomatic, you don't have any concerns at that point. So I think, you have to think about it, about how close are you already to meeting the CDC criteria that even if you had gotten infected and tested positive on day 5, you're already at day 9 or 10. There's probably no great reason to go out and get a test at that point. So partly it's an individual decision, but that's part of the challenge that we have. But we do know that if you get tested very early after exposure, a negative test could be false negative. The other question about rapid tests that comes up all the time. So there are basically 3 different types of tests that are available for COVID-19. The first is the antibody test, which for the most part is rapid. It's the finger stick. It is the one that you see at urgent cares. You see it in pictures all the time on the news media. They show the little red line on the little white thing that somebody's put their blood into. That's the antibody test. It's of no value. It should be used in research settings only. Those rapid antibody tests are essentially of no value. They don't tell you anything. If they're positive in Oklahoma, they're just about as likely to be a false positive as a true positive. So don't tell you anything. They don't help you. If they're negative, you may be comfortable that you've not been exposed in the past, but antibody tests of no value. The other rapid screening tests that are being done, again, in a lot of urgent care centers are the antigen test, where they do a swab and they're testing for viral protein. Those tests, when they're positive, are pretty good. If they come back positive, they're typically a true positive, but they have a very, very high false negative rate. So if we have a patient that's had one of those that's negative, we don't believe it, and we do PCR testing, which is still the gold standard test. So lots of people selling the antigen test, lots of people doing them. Again, a positive, I think, is a pretty good result, and I would take it seriously. A negative, that even the company reports that they have a high false negative rate.
All right. We've got time for about 2 more questions. Again, if your question has not been addressed in the chat room, I will compile those questions. You can send those to the Staff Senate email address, and we'll get those to Dr. Bratzler later. The next question, how effective do you think Oklahoma's contact tracing is?
Well, it's getting better, but Oklahoma, so we've had all sorts of different problems. Number one, we've had huge delays, as people know, from labs getting their results to the state health department. So sometimes the health department isn't even finding out somebody's positive until 7-10 days after the test was run, which is, quite honestly, is way too late to start even thinking about contact tracing. So that's been part of it. Second, let's face it, public health in general in the United States has been underfunded for years. Has seen about a 30% cut in their budget since 2002. and they weren't prepared for this pandemic, and they didn't have the staffing available. I know Dr. Wendelboe from the College of Public Health, who'd been the interim state epidemiologist up through last Monday, highlighted that they had hired 300 contact tracers and had about 160 more in training right now. But again, when you're seeing 1,000 new cases a day, it's real difficult to keep up with that volume of people, because remember, person tests positive, somebody has to call them, has typically an hour and a half call with them, detailing where they've been, all the things they've done, all the people they've been in contact with, then comes up with a list of people that now have to be contacted. So it's a quite time-consuming process. And then ideally, those direct contacts get tested if we want to contain the disease. So it's getting better in Oklahoma. On the Norman campus through the Goddard Health Center, Maggie Pull and her team are actually in a contract working directly with the Cleveland County Health Department, and we're doing some of the contact tracing right out of the Student Health Center, and we're looking at a possible contract with the State Health Department and the Oklahoma County, City County Health Department around doing our own contact tracing on this campus. The one thing for all of you that are staff, management in any way, one thing I want to highlight, Jill, you'll give me a gold star for this.
I'm listening.
You cannot, if you have an employee that tests positive, you cannot give out their name. That's a HIPAA violation. You need to go through contact tracing and the appropriate channels. You can't just go start telling people that somebody tested positive. If they want to tell people, that's fine, but you can't do it. That would be a HIPAA violation.
All right. We got one more question in the interest of time. The question is regarding the gym. Do you feel it's currently safe to go to the gym if I take proper mask precautions?
If everybody's in a mask, I think it's reasonably safe. But you breathe hard in a gym when you're working out, and so you probably shed more virus if you happen to be infected. So, and that's been my frustration with some of the masking ordinances that have been passed, that they've been giving gyms, particularly for aerobic activity, which may be the most aerosol generating. And they've been giving them this pass that it's okay, you don't have to wear a mask when you're doing that. We make the OU athletes wear a mask regardless of what they're doing, unless they're outdoors and physically separated.
All righty. Do you have any final comments for us, Dr. Bratzler, as we wrap up?
No, I really, I appreciate everyone and the questions, and we're all learning how to navigate this. And again, I give high credit to Joe Raines, who's led a lot of these efforts on our campus and all three of the Norman campus, the OU campuses. There's a big group that are meeting constantly to try to figure out the best way that we can keep students safe, staff safe, faculty safe, keep our patients and the visitors safe on our campus. It's really been remarkable to watch everyone pull together to work on this pandemic. And we've actually done a very, very good job, I think, particularly within our own system of keeping people safe. So kudos to all of you too.
Well, thank you again, Dr. Bratzler, for sharing this important discussion. Your leadership has just really been invaluable to us, to our families, to our campus, and certainly our community. We so appreciate your time today. Thank you again for being with us. This actually concludes our August meeting. Please join us for our next Staff Senate meeting, which will be held on Thursday, September 3rd via Zoom. Thanks, everyone.